Good morning. My name is Valentine Anye, the student nurse who cared for Mr. JB throughout the night shift. This is a bedside report. This is a report on Mr. JB, an 85-year-old male who is a full code and was admitted following a traumatic brain injury with cerebral hemorrhage resulting from a fall. His hospitalization has been complicated by multiple rib and spinal fractures, and he currently presents with right-sided hemiplegia and significant cognitive impairment. He has a tracheostomy in place for airway management and receives nutrition via PEG tube due to severe dysphagia. Mr. JB is a total care and fully dependent on staff for all ADLs. He has a past medical history of traumatic brain injury, seizures, osteoarthritis, chronic joint pain, cognitive impairment, and aspiration risk. Throughout my shift, his vital signs remain stable. Blood pressure ranged from 132 on 78 to 140 on 85 millimeters of mercury. Heart rate was between 88 and 96 beats per minute, and respiratory rate 20 to 24 breaths per minute. Oxygen saturation maintained between 97 and 99% on 40% oxygen via trach mass. Significant assessment findings included altered mental status. He is alert but disoriented to time, place, and only inconsistently follows commands. He experienced frequent episodes of diarrhea throughout the shift, which required ongoing incontinence care to prevent skin breakdown. I applied a protective barrier patch to his sacral area and repositioned him every 2 hours. His skin remained intact. A midline catheter was removed earlier in the shift, and due to suspected urinary retention, a bladder scan was performed, followed by successful straight catheterization. Lines and drains included a functioning PEG tube with no signs of infection or leakage, and a tracheostomy that remained patterned. Suction was performed as needed. Secretions were thick but manageable. Relevant labs included glucose of 208 milligrams per deciliter, BUN of 24 milligrams per deciliter, and creatinine of 1.3 milligrams per deciliter, which is slightly elevated. His albumin is low at 2.7 grams per deciliter, which may reflect poor nutritional status due to PEG feeding. White blood cell count is mildly elevated at 12,000 per millimeters cube, and I have notified the provider about the persistent diarrhea in case of underlying infection or feeding intolerance. Interventions during the shift included scheduled PEG tube feeding, medication administration, where guaifenesin, tanzanidine, and atorvastatin was administered, blood glucose monitoring, incontinence care, repositioning, and straight catheterization. SCDs were in place throughout the shift for DVT prophylaxis. I also provided patient education, particularly on PEG and trach. For the oncoming shift, I recommend continued monitoring of bowel patterns and evaluation of possible feeding-related diarrhea. Monitor blood glucose levels for ongoing elevation and maintain skin precautions and safety interventions. Continue suctioning and chest physiotherapy as scheduled. Mr. JB prefers low lighting and quiet surroundings. He becomes restless with loud noise or unfamiliar stimuli. He responds best to simple, calm verbal clues. A warm blanket was provided per caregiver's note that he dislikes being cold. No family was present at the bedside today, but I did speak to his daughter, who is the primary caregiver, to provide an update on his condition. Thank you.